Sir, is it visible? Shall I put it on the slideshow mode?
Yes, you can put it on the slideshow mode, please.
Yeah. Shall I use the headphones or this audio is okay?
Audio is perfect, sir. But we can't see your slides right now. I can see your screen, which is the folders, all the folders.
Just sharing it.
Yes.
Now?
Yes, please. Yes, perfect, doctor. So we have about 66 people who have joined us already. Let's just wait for a minute, I think. Let the rest of the people join in, and we can then proceed, sir. Dr. Khaleel, with your permission, I'd like to start now.
Please go ahead, sir.
Thank you very much. Good afternoon, ladies and gentlemen. A very warm and hearty welcome to this lovely Saturday afternoon, where JMitra welcomes you to the webinar titled Vector-Borne Infections, a Deadly Scourge. We're very pleased to have with us today Dr.MohammedKhaleel, MD, Professor in HOD Microbiology at the Mahavir Institute of Medical Sciences. Dr. Khaleel has an distinguished career for multiple decades in the medical fraternity, and we are very pleased that he is here to share his experience and learnings with us on the subject of vector-borne infections, which constitutes a serious and deadly threat to India today. Without further ado, I hand over the forum to Dr. Khaleel. Dr. Saab, please proceed, sir.
A very good afternoon. Perfect 12 o'clock, and it's honor and privilege to have this on this educational platform, which is not sponsoring or taking advantage of that. I really appreciate the JMitra and company and all. And it's been an honor. We had a trial of the presentation. I had shared my presentation, and I am just going to speak on Indian perspective point of view, because it's a very big topic. If you just keep on covering, I mean, there are pandemic all over the globes on the continents. But I thought keeping in mind the target audience, I'll totally focus my talk on the Indian perspective point of view. So the need of the hour, because we have a lot of global warming, deforestations, and left out with no other source to control these vectors. So I thought it's a talk that has to be delivered and knowledge to be shared. So having said that, we'll go to the next slide. Yeah, the learning outcomes of this session would be, I will giving you a definition of the what is vector exactly and what are the infections, and then different types of transmission, the clinical features, what the patient undergoes, and finally the most important part, the laboratory diagnosis. Just making sure again, if I'm audible and visible to all of you.
Absolutely, sir. Loud and clear.
Okay. Thank you. Yeah, what exactly is a vector? It's they are living organisms basically, and they can transmit infectious pathogens between humans, I mean human to human, and also from animals to humans. So let's be clear on this concept that they are living organisms. They could be arthropods, that is jointed legs, and there are two types of vectors basically looking at this. Before that, I would like to give a talk, just touch upon how important and why we should talk about the vectors, because as you can see, they account for more than 17% of all infectious disease. Why I'm telling infectious? Because they spread infections. They spread infections from human to humans. They spread infections from animals to humans, because most of the animals or birds here, they act as amplifier host or a reservoir host. Let's keep that in mind somewhere. And we're talking about the burnout problem. There are about 7 lakh deaths annually because of this. So, having said that, there are two types of transmission by these vectors. One is the mechanical transmission, where the agent doesn't have to replicate or develop in or on the vector. I mean, the agent, I mean to say the infectious agent or the infectious organism. They do not take the advantage of they themselves being in or on the vector. Terms like cyclopropagative or cyclodevelopment, which occurs in malaria and filaria, is nothing concerned with the mechanical transmission. They just pick up and transport it to another part, another place. So from one animal or environment to a human being. Very good example that can be quoted is housefly. Housefly is a vector which is a which helps in the mechanical transmission and helps in transmission from another human to human or from the environment to the human being, and they can spread diseases like cholera, salmonella, stuff like that. Coming to biological transmission, yeah, it is taken up by the vector, usually through a blood meal from an infected animal, and following which, as I said here, the vector, the organism replicates actually, which replicates and or develops and subsequently is regurgitated onto or injected into a susceptible host. So here two things here, very important carry home message is here, they take the advantage of themselves being in the human organism or in animals where they totally dependent on to continue the life cycle. So it could be human or an animal or a bird where they can take them as an amplifier or a reservoir host. And I mean, there are a lot of vectors like this. It could be your Anopheles, your Culex mosquito, your sandfly, your red wheat bugs, diseases that are spread like rickettsia and all. Very common, the common vectors in India or the common infectious agent or the organisms or the infections that are very common in India are hemorrhagic oriented. I mean, there are diseases or infections like dengue, chikungunya, Casinor forest disease, which can lead to hemorrhagic manifestations. Then you also have Japanese bee, which is transmitted by Culex mosquito, which can cause encephalitis-like syndrome. Then you have very rare, let's not also forget the area which are in the BD, that is Maharashtra, Odisha, Bihar, where you have the Ganjam, Vellore, Chandipura, and Banja. Yellow fever, let's not talk about it because it's not prevalent in India. So my topic would be concentrating on this dengue, chikungunya, KFD, which leads to hemorrhagic manifestations, in Japanese bee, which can lead to encephalitis, and also malaria, which is caused by Anopheles mosquito. Yeah, these are some image-based pictures of these vectors. Like you have Aedes aegypti, which you can recognize by the bands of white and black over them, which is also called a tiger mosquito. Then you have a lot of ticks. You have a lot of fleas. You have a lot of flies like sandfly. You have your Culex mosquito. You have your Anopheles mosquito. There are features where you can differentiate between each of them, but that is not today's topic. Let's talk about the pathogenesis. Yeah, these are the vectors which can lead to different syndromes. Like it's, as I told you, biological transmission. So it could be a bite or injection or inoculation, or it could be just the regurgitation of the fluid or the vector being on the human skin, and its excretion could lead you to scratch and itch. Because of that, and you having a non-intact skin can be a route of infection. So, and hence the organism present in the vector could transport to the target organs through the blood or the lymphovascular system and affect the reticuloendothelial system especially, which can lead to fever, rash, and hemorrhagic manifestations. Very common. That can be because and also resembles non-specific illness. Like you might have this kind of symptoms in your allergic symptoms, like in influenza, rubella, and enterovirus infections, which can affect your GI, which can affect your reticular endothelial system and your vascular system. And very good examples for this, where you have a fever, you have a typical rash, and you have a hemorrhagic manifestations, could be because of your chikungunya, dengue. Then you have encephalitis-like syndrome, which affects your central nervous system. Here you have a mosquito borne, especially caused by Japanese B encephalitis. So let's talk about the viral diagnosis. Very simple. First is rapid test. Everybody knows. I mean, if we have about 180 participants, and everybody does this in the lab as a screening method, as a provisional diagnosis. Rapid test, that is an immunochromatographic test, to just let you know the earliest marker, or might be an antigen simultaneously, IgG and IgM. Very good example I could quote is your dengue dual test, where you know the NS1 antigen at the same time IgM IgG test is also done. Rapid test, most commonly used, most simple, cost effective. Yeah, microscopy is also used. Let's not forget that not commonly used microscope doesn't play a big role in virology laboratory diagnosis as compared to your bacterial, where you do staining and then try to focus under the microscope. But here you use an electron microscope if and in case you need to appreciate the morphology of the virus. Again, coming to the isolation, when you want to go into the research part, your publication part, you want to exactly know the perfect, the specific areas of your virus, then you can do cell cultures. Then you can, most commonly, another very common thing that you do in laboratory diagnosis of viruses is a serology. Everybody agrees with me that ELISA is most commonly widely used tool, with good specificity and sensitivity, detecting your IgM or IgG to differentiate it for acute or a chronic infection, or a primary or a secondary infection. Also, it gives you the titers. Last but not the least, molecular techniques, when you're not able to get through this, uh, the screening part and your serology part, but still the doctor suspect it could be a viral infection, then you go for the molecular, you have the PCR. So let's talk about the required specimen. As I told you, you have a fever, you have a rash, you have encephalitis syndrome. Then definitely the samples would be blood, the serum of the whole blood, or the CSF if it's an encephalitis-like syndrome. Most common sample used is blood here. So what do you do with blood exactly? You want to make a diagnosis of vector-borne infection. So you use hemagglutination assays inhibition test, using sheep RBCs. You do use a microtiter plate, and you take the patient sample, and you add this, and you do proper dilutions. Depending upon the interpretation, whether there's a button compact thing formed, you can titrate it very nicely, or you can go for a complement fixation test with an AMBO receptor. And finally, not the least but very important, ELISA. Virus solution, as I already told you, you can use, especially when you're going for experimental research purpose or development of vaccines. You want to understand the pathogenesis of viruses, as we have like H5N9 new bird fly virus, or new viruses that have come down. Like everybody has gone through the pandemic. You start experimenting on the mice, the guinea pigs, or the chimpanzees. So use them there. You inoculate through different routes, intraperitoneally or intracerebrally, and you try to understand the pathogenesis, you isolate it, and you try to prepare the antidote or the vaccine against it. Cultures, several cell lines have been used, including the mosquito lines. You have the Vero kidney cell lines, then you have the baby hamster kidney cell lines. And fine, there's another method when you're talking about vector-borne diseases and trying to know diagnosis. There's something called zero diagnosis, where you try to know or elicit the diagnosis using the vectors, okay, or the vectors which transmit the infection. And to the mosquitoes, you study the pathogenesis and try to isolate the organism from the vector itself rather than the human, which is called xenodiagnosis. Xenodiagnosis, xenodiagnosis. Yeah, let's talk about some direct test where you just take the sample and inoculate. You can use the PCR, or you can isolate the nucleic acid. But again, there are safety issues. I mean, what I mean to say is you take the sample and you try to isolate the virus itself as such. But for this, mind you, you have to have a very good sophisticated lab with biosafety level 2 or 3, where you have all the negative pressures and you yourself don't get infected with that when you're trying to isolate the antigen of the virus or the virus itself or the nucleic acid of the virus. Yeah, let's talk more on serology. Most widely used method for detection, as I said, would be ELISA, where you try to make diagnosis as primary infection. If an IgM is detected, IgG is good, but the only problem with IgG is you're not able to make whether it's a chronic infection or a past infection. And if you're talking about diagnosing IgG in neonates or newborns, it could be a cross infectivity because of the maternal IgG immunoglobulin. So hence, it could be only significant only when there's a fourfold rise in titers in IgG. Okay, when you are able to do two sample tests between acute and convalescent sera, which makes it more significant. So fourfold rises or more increase in titer of IgG would be good. False negative are seen in patients in a seroconversion period. I mean, when the patient is convalescent phase or when he's able to go from a acute to a chronic phase and all, he has the symptoms, but when you do a test, it comes out negative. Now, that's the dangerous part. I mean, this is a area or the result which microbiologists do not like at all. I mean, the patient has the doctor suspect, but the result is coming negative. But you have to keep in your mind when you are interpreting your report, you have to have a clinical footnote written down that this could be the reason why it has come false negative, or this by the reason why it could be false positive results. And now false positive could arise because of the cross infectivity of closely related species. It happens in most of the bacterial infections. It happens most of the parasitic infections, your vector-borne infections, where because of the same vector being transmitted or because of the similarity in the genome relatedness, there could be a lot of false positive, biological false positive. You have to rule that out when you go for serial double dilution test, where you want to make it more specific and you can give it in the results in titers. Let's talk about chikungunya. Yeah, it's one of the re-emerging diseases characterized by severe fever and uncompromised arthralgia. I mean, you have severe joint pains. As I think everybody knows, the vector is Aedes aegypti, which is a household container breeder and aggressive daytime breeder. Now, this is very thing that you have to boldly underline cap locks. Worth listening again. The transmitting agent here is Aedes aegypti, which is a household container. That's the reason why we are not asked, or the government as our epidemiology people are request or instructions through social media and all to avoid having stagnant waters, these tires, or your household utensils, or keeping your surroundings clean and all, because your chikungunya and your dengue, because they have the common vector which is Aedes aegypti, and it's not a nocturnal, it's a daytime feeder, and it resides, it habitats in these areas of the stagnant water, your old tires, household utensils, unused or condemned utensils and also, and keeping your surroundings clean. Yeah, talking about typical arthritis over in chikungunya, it is polyarticular or migratory edematous. I mean, it involves a lot of joints, especially the joint joints. It's something your joints become so much edematous. It's called as swollen up or double up joint pains. Okay, and as I said, predominantly affects the wrist and the ankles. And other symptoms could be like any other viral infections. You have a severe headache, you have myositis, you have tenosynovitis, the layers covering the joints, and also skin rashes, minimal of skin rashes in chikungunya compared to your dengue. There's also a new vector that is Aedes albopictus, and the difference which I'm going to talk in 2 minutes, a few minutes from now, how you differentiate Aedes aegypti from albopictus. This is also a vector that also can spread your chikungunya. Yeah, this is a major difference between your dengue and chikungunya. As you can see, that fever is common in both of them. Now, it becomes very difficult for a clinician to come to a judgment or take a call when you have a patient with this kind of symptoms. That's the reason why here the lab will definitely help uh, the clinician as a supplementary. As you can see, polyarthritis and tenosynovitis are very, very, very common in chikungunya, and the onset of rash is very, very early in chikungunya compared to dengue, which is about 5 to 7 days, a bit late compared to chikungunya. Now that's how you elicit from the history from a patient. And whereas symptoms like myalgia, leukopenia, thrombus, platelet fall, drop in the platelet, and very specifically, let me tell you that retroorbital pain is very, very specific in your dengue fever, which is very rare in chikungunya. And hypotension, minor bleeding, that is the petechial hemorrhages, which is we call because of light minor capillary leakage and all, plasma leakage at the junctions, because the immune complex antibody dependent mechanism, the immune complex deposits at the capillary areas, and they have a lot of capillary leakage which lead to petechial hemorrhages and cause minor bleeding. So this is how you differentiate chikungunya from dengue. Let's talk about the third culprit, that is the Japanese bee encephalitis. Now this is known to be a leading cause of viral encephalitis in Asia, including India. And it was so named because it was there was one Japanese A encephalitis which was first seen in Japan, which is also known as summer encephalitis epidemics. It was known to cause a lot of epidemic outbreaks, and this, I mean, the Japanese bee, and it was to differentiate from encephalitis A, which was endemic actually during that time. So you have to just let me repeat this: the encephalitis A causes epidemic, sorry, the endemic during that time, and there was also another virus uh, which causes Japanese bee encephalitis that cause epidemics, and it was named as summer encephalitis epidemics. So that's the reason why, just to differentiate, it was named as B, to differentiate from A, which causes encephalitis lethargic or Van Economo disease. The vector is Culex mosquito, no doubt about it. And the species which is responsible for Japanese bee encephalitis is Culex trichinorhynchus, which is a major vector worldwide, including India. But also there's another species which was discovered, Culex vishnui, which is the next common vector found in India. Yeah, vaccine preventable. Almost all the viruses or the vectors which I am talking here, it might be chikungunya, dengue, Japanese bee, they're all vaccine preventable disease. So hence it is our duty to make people aware, the community, and make them sensitized that these are all vaccine preventable diseases. Yeah, as you can see, Japanese encephalitis infects various other extra humans like animals, birds, especially the pigs, and the edrid birds, especially, which is also called heroin, Heron. And as you can see, you have this pigs which acts as amplifier host. So when the mosquito, Culex mosquito bites, injects the organism into the pigs, you have a lot of amplification, multiplication that undergoes in the pigs. And you also have edrid birds or the heroin birds, which acts as the reservoirs or the carriers. I mean, that's how it maintains its life cycle in the nature. And man is an accidental host, unfortunately. And very reasons for epidemics are your deforestation, your agriculture development because of this, and construction of dams, irrigational canals for rice cultivation, especially rice crops. Wherever you have this, it is more prone in this area, the Culex B virus or the vector. Right. Okay, now let's move to the next slide. Yeah, man, as I said, is an accidental host. Yeah, you have this all the symptoms of Japanese bee encephalitis. As you can see, this child is having uh, lethargy. He is sudden fever, headache, vomiting, diarrhea, weakness, malaise, irritability, and restlessness. Finally, because the brain is involved through the blood lymphovascular, then the CSF is involved. You have the tremors and convulsions. Altered sensory. Laboratory diagnosis, what you do exactly is, yeah, you take the specimen or the blood, because it starts with the fever and all. So you do the same test as I tell, the gold standard ELISA, heme agglutination inhibition test. Then you have the neutralization test. You confirm it by detection of JE virus itself. I mean, when you try to isolate it, or the antigen, or the genome in the CSF, blood, or tissue by immunofluorescence or the PCR. Because now I'm talking about the confirmatory test. So then you go for a molecular or immunofluorescence test. The samples would be CSF and blood. What you are going to detect? The genome, or the antigen or the virus itself. And you can also do an ELISA test. As I already told you, let me remind you again that there should be a fold 4 rise in titers compared to your baseline and in your paid sera when you're going by ELISA. You can also use cell lines, like especially the cell lines which are used for Japanese B encephalitis are C636 cell lines. And you can also do an IgM capture ELISA. And might keep in mind that there are a lot of cross reactivity when you're talking about Japanese B isolation or detection, which cross reacts with dengue viruses and also your West Nile viruses. Yeah, let's talk about the dengue. As you can see, the entire the country of is prevalent the dengue virus, most common in your the Gujarat, the Pune, Maharashtra area, the South Andhra, Telangana, and mostly the Kolkata. When you're talking about North, you have the Jammu, Delhi, the Jaipur, Ajmer, Kanpur, and Gwalior, and mostly coastal areas. As you can see, Tirupati, Chittoor, Vellore, Chennai, very, very common whenever there's an outbreak. So tropical, subtropics areas are covered. You have 4 serotypes from dengue 1 to dengue 5. There's also a fifth dengue serotype that has been discovered from Bangkok, 10 years down the lane from here. Now, why I'm talking about serotypes? Because the infection is very type specific. I mean, you have infection with type 1. You go through the process of infection. You have fever, you have rash, you are treated, your body develops antibodies against type 1. And again, when you have infection with type 1, because your memory cells are there, your immune response is already developed. You won't have infection with type 1. This is called type 1 specificity. But because of antibody dependent enhancement, because if you have infection with type 2, your antibodies that are developed in your blood, in your body, is against type 1, not type 2. But because they belong to the same family, they might be cross reactivity. And because of serotype 2 and antigens, and you have serotype 1 antibodies, cross reactivity occur. A lot of immune complexes will develop. They don't get resorted or resolved. So they deposit in the capillaries, and there'll be a break. There'll be a plasma leakage. All your hemocritic values will go up, PCV or MCHC or whatever values, and your platelets will go down. That's the reason why doctors keep on monitoring your platelet count, just to know the progress and how the clinical condition of the patient, along with your serological markers in the microbiology lab. Aedes aegypti, as I told you, is same vector as you had in your chikungunya. It's a daytime brighter bite. You have now the difference between Aedes aegypti and albopictus, as I promised, would be clarified here. It's a nervous feeder, so it bites repeatedly to more than one person. Why? Because it has to complete its blood meal. What I mean to say is, at one shot, as you have albopictus, which covers at one shot. See, albopictus found in peripheral urban areas is very aggressive, and cocodon fever can complete its blood meal in one go. I mean, it sits at one patient, it sits at one place, it sucks the blood, and one meal it's filled up. Whereas Aegypticus is not like that. It has to keep on going from person to person, resides in domestic place. And that's the reason why Aegypticus is more efficient in transmission infection when you compared with albopictus, because it keeps on traveling from patient to patient to complete its blood meal. Both are daytime feeders. Yeah, let's talk about the clinical syndromic this approach. You have virus infection. Either the patient could be asymptomatic, who could just be a carrier, or it might be previously is infected and has antibodies developed, so nothing happens. It doesn't have any symptoms, or symptoms where you have undifferentiated fever, because it's very, very difficult, because viral infection is something like, I mean, so many things run across your mind. I mean, your brain, it could be chikungunya, it could be dengue, it could be malaria, it could be filaria, it could be brucellosis, any bacterial infection, TB, you name it, it's there. Salmonella, we don't know initially. So undifferentiated fever is one category. Then you have a dengue fever syndrome, which has an unusual hemorrhage, or it could be without hemorrhage, depending upon the stage of clinical illness. Then you have finally the third stage of dengue, which causes a lot of plasma leakage, which is called dengue hemorrhagic fever, where the patient has to be monitored. He has to be admitted in ICUs. The conservative management has to be done. All his vitals and parameters have to be checked time to time. Or if not treated, if not properly monitored and follow up, he might land up with dengue shock syndrome, which might lead to hypovolemia, shock, and it will be very fatal, leading to death or coma. Clinical findings, yeah, incubation period is 3 to 14 days with onset of fever, which is biphasic, saddleback fever, it's called. and patient will complain of severe headache. Now, very specific finding in dengue as compared to chikungunya, as compared to other viral infections would be your retroorbital pain. Patient will have a lot of conjunctival sufficing, pain in the back, limbs, lymphadenopathy will be there, macular papular rash will be there, but you don't have the typical joint pains, double up joint pains, or involvement of polyarthritis as you had in chikungunya. That should help the clinician when you're talking about the clinical diagnosis. Yeah, what are the factors affecting your determining the outcome? Yeah, you have, as I told you, type 2, when you're talking about 5 types, which type is more dangerous or more fatal? It is type 2 that is more dangerous compared to serotype. That's the reason why some doctors or clinicians who are academically interested, research oriented, they also want to know which type or which serotype it is. And when you're talking about sequence of infection, any individual who has type 1 followed by type 2 seems to be more dangerous and can land up with dengue hemorrhagic fever and settle down with dengue shock syndrome. So it's very important for a doctor to know. That's the reason why you have a lot of deaths in dengue, because you don't want to go further investigation. You're not interested in what exactly is the serotype. You just stop it's dengue and you think it could be treatable or curable. You have to go into depths. You have to have a close watch, meticulous diagnosis, treatment, management has to be done in case of dengue. Though all ages group are affected, but children below 12 years are more prone to develop dengue hemorrhagic fever and dengue shock syndrome because of the immune system. Yeah, as you can see this pic, what are the virology, the course of dengue infection? I mean, when you're talking about the primary infection, you have the earliest test that you can do in a patient is NS1 or the viral RNA by a PCR. Somebody comes and says, what is the test? I want to know whether I have a dengue or not. So when 3 to 5 days, if you're talking about 3 to 5 days of illness, you can do an NS1 antigen test, a rapid screening test, or might be followed by an ELISA test, which is more specific, and or you can do your RT-PCR test, RNA, viral RNA, followed by your IgM detection, which is again 7 to 14 days. Let me repeat again: 3 to 5 days it's NS1, 7 to 14 days it is IgM, and you have 14 to 28 days it could be IgG. Now this is the clinical stage of illness where you should know what test to write to a patient. Fine. Secondary infection, you can go for IgM because IgM is a marker for your acute infection or primary response. Therefore, you have very meager levels of IgM, whereas you can have high levels of IgG. Okay. And risk of secondary disease, like secondary more severe compared to primary dengue infection. So that's not good. And this could be because of different serotypes affecting the patient. As I told you, because of the antibody depending enhancement, it could lead to the immune complex, capillary leakage, all these things can occur. So this is one thing. And second good slide which you can learn is, we're talking about specificity and sensitivity of the test. Yeah, virus isolation would be the gold standard, but as I said, you have to have a very good sophisticated lab where you trying to isolate the virus itself and study the genome and or the antigen detection. So these are all direct methods which have already been discussed, but they are very specific, mind you. Coming to the sensitive test, where you can even pick up the minute amounts of the virus in your blood, you can do a rapid test. You can do a serological test by ELISA, or you can do hemagglutination inhibition test, or you can do your neutralization test. Also, you can do immunofluorescent test when you're talking about direct. Now, keep talking about the test. Let me mind you, because it's not sufficient that you just do a rapid test, because as I said, they can be false positive. Though the specificity sensitivity is very good, though its advantage is very common, very cost effective, very cheap, and time turnaround time is very less. You can just report, but it's provisional still. It's still provisional. And as a government, every government of India has also released that you shouldn't report it as positive or negative, just depending upon the test results from rapid. You have to confirm it by ELISA test, and you have to report definitely by ELISA after doing ELISA only. It's a thing that it's a disease like tuberculosis where you have to report to the government authorities. Yeah, talking about the treatment, there is no specific antiviral therapy as such, because they're all, most of the viral infections, you don't start on antibiotics. Conservative management is the goal, and symptomatic supportive treatment, you just give dolo depending upon the fever and the depending upon the intensity of fever, the frequency of the what do you call antipyretics can be adjusted. As electrolyte imbalances occur, try to replace the plasmolysis, correct the electrolytes, metabolic disturbances, platelets transfusion if required. Definitely there would be when you keep on doing your CBP and all. Then talking about another very important organism or the vector without which my presentation would be complete, malaria. As you can see, this is a life cycle of malaria, and everybody like from 7th, 8th class school, you know that you have an exoerythrocytic cycle, then you have a erythrocytic cycle, and the definitive host is mosquito, not the man, because the sexual cycle occurs in mosquito. Sporozoite is the infective stage, and I'm not going to talk about the typical life cycle and all. I just want you to know that man is the intermediate host because asexual cycle occurs in man. And finally, the stages that come out are the gametocytes, the male and the female gametocytes, which is picked up by the mosquito. I mean, these are there in the peripheral circulation. Now, this is a sample. The sample for diagnosis of malaria would be the blood, peripheral sample blood. I mean, would be a puncture from the pulp of the finger or the blood itself, and you make smear out of it. I mean, this is the area where you have to concentrate the sample. Okay. Lab diagnosis, microscopy would be still the limelight. You do a blood smear, a spatula, and everybody knows that you have to have a two slides, and once you have the blood drop on the one end of the slide, you put it at an acute angle, just go back and push it up. You have a spatula or tongue shape smear form. Now you have two smears here, you have thick smear and a thin smear. And you use different, what do you call this, Romanovsky stains, that is bright stains. You use JMitra, you use Leishman stain, you use Jaswant Singh Bhattacharjee field stain, depending upon your work area and your easiness. But there are different stains and all that you use for malaria, and almost all vector borne like your trypanosoma or babesia or leishmania, your filaria. So these are the stains used. You make smear, you stain them. Now thick smear is used for identification and quantification, whereas thin smear is used for specifications. Basically, the intensity of the width of the smear which you use, where you use much pressure, you have one line thickness, it is thin. Where you have 3-4 lines thickness, it is a thick smear you make. Then you do a very important technique, QBC technique, quantitative Buffy coat. It's a very rapid method of detection of parasites. Only thing is you use a fluorescent dye over here, and you have a special centrifuge tube, very thin, a capillary kind of tube, where you insert this blood and you put it in a microcentrifuge with 15,000, 20,000 RPM, and you have different layers, and you which is separated by the platelets and other debris and everything. You take this Buffy coat and you put it on the glass slide, you smear it, and I mean, you can see that all the stages or the gametocytes are teeming at you. I mean, you can just, it's very clear for you for diagnosis now. As one of the picture that is placed over here is a peripheral bed smear of a JMitra stain. It's called headphone appearance, which is very typical of your aracol forms of your Plasmodium falciparum. Fine. The rapid test immunogrammatic tests are very rapid, simple, cost-effective turnaround time. You do a para-lactose dehydrogenase test, which is for pan malaria, because there are 4 to 5 species of Plasmodium, vivax, oval, malaria, and you have no resi. So pan malaria detection can be done with para-lactose dehydrogenase. And histidine-rich protein 2 is very specific for your antigen-rich for Plasmodium falciparum. Now that is the most fatal, which causes cerebral malaria or algid malaria now. So that's a rapid test. Serology, not much done. IgM, IgG, by laser titration can be done. Molecular diagnosis would be the last in the lane, which can be done by PCR. But otherwise, malaria on clinical judgment, signs, symptoms, and your rapid test, and which are very good with good specificity and sensitivity, will help you out to cleanse the diagnosis of malaria. Yeah, let's go to the next slide. Control of, yeah, having said about now about your dengue, chikungunya, Japanese bee encephalitis, the malaria, and also your filaria is also one more parasite, which is again very common in the tropical areas where the vector is Culex, which can also spread Japanese bee encephalitis. You have another Culex which can also spread filiasis, which affects the lymphatic system, in fact, which can cause edema of the leg and all those organs, areas which is very rich in lymph. lymphadenopathy or lymphadenitis or lymphangitis. So this is another thing which I couldn't put in the slides. Filaria is also very common. You also have some what do you call eradicated or like dengue, what the guinea worm, where cyclops can also as a vector. There is also vector-borne disease, which is very common in step well, where you had that. That's also condemned. I mean, the usage of step wells have stopped because of this. Cyclops found very common in those water reservoirs. Other vectors like you have ticks, mites, and fleas, which are not that common in India. But there's one flea which causes rat flea, which causes plague through rats, is one vector-borne disease. Another thing which can very common in India would be your mite, which can cause scrub typhus, especially areas where you have a lot of vegetations, which can cause ischar, that is a blackening of your skin, and the chiggers, the larvae of the mite, is very much responsible for this. It's a zoonotic tetrad, in fact, which can cause very common in farmers and agriculture workers and all. People come down with fever. Another very important thing I thought I should discuss here on this platform is leptospirosis, where the patient comes with renal failure, your liver failure. When you do the RFT or LFT, you come to know that there are a lot of raised bilirubin, urea, and the kidney, your serum creatinine, uric acid, abnormal parameters. You have jaundice icterus, and upon investigation, you have this microagglutination test, which is very specific for leptospirosis. Again, this is very common. It spreads through rats. It's a spiral organism with what do you call lax coil with hooked ends, and very common in Andaman Nicobar Islands. Again, very common in rice field areas. Like another thing that's very common in coastal areas in India. So I thought this is another areas: filariasis, leptospirosis, or scrub typhus caused by mite are things which you should consider. You also have things like leishmania. You have Trypanosoma cruzi and bruzi, which are very common in Western countries. Your South American, you have Francisella tularensis, which is again caused by tick. You have Rocky Mountain spotted fever. Again, we're not that common in India, so I thought I wouldn't cover up this. Finally, last but not the least, yeah, we have how to control this. I mean, we have learned about what are the different vectors, what is a vector, what are the different transmission routes. We learned about the laboratory diagnosis, the clinical features, how to differentiate each and every vector from other vector-borne diseases management. Now, last but not the least, how to control these vector-borne infections. Yeah, the government of India has come out with another good plan of One Health, where you have to have a very collaborative approach, where it's a multidisciplinary fields try to get involved. It's not only the human or the medicine, the health, human health involvement. It's also the agricultural people. It's also the aquaculture. It's also the all have to come under one umbrella. It's the responsibility of each and everyone, the administration, local, national, global, at each and every level. Everybody has to give their outputs, and hence what has to be done is we have to break the chain of transmission and try to have the infection under control. There are a lot of vector-borne disease control programs that have been laid down by government of India, and it's taking up very seriously. Like you have the National Malaria Control Program, the Filarial Control Program, the Kala Azar. Then you have Japanese bee control programs, dengue and dengue hemorrhage control program. Now, how do you do it? You have a lot of what do you call this? Sprays and pesticides, you anti-larval, and also you have anti-adult. Uh, First thing would be sanitation, taking care of the sanitation, keeping your environment clean, keeping your household area in and out, external environment clean. Feel the responsibility as a citizen of your country. Try to love the country. What I feel when I've gone outside for international stock and all, I was surprised to see that they do not spit or urinate or throw anything. They take all the pain to go to the nearest or the farthest dustbin, but they make sure that they throw it in the dustbins. So that culture has to come in our country. I mean, our country is so diverse with such a background of different religion, sex, caste, and all. So everybody should feel that responsibility. Then only you can say that you love your country. Unless we keep our surroundings clean, we cannot. It's very difficult task to eradicate or eliminate this kind of diseases, a bacterial, viral, fungal, and all. So you have a lot of sprays like you have malathion and synthetic pyrethroids as drugs. Uh, you have DDT actually, diphenyl trichloroethane. But you also have you call what do you call this benzene hexachloride. But the problem with benzene hexachloride, it has a very musty smell. and you can use for mosquitoes and sandflies. And you have malathion because DDT has its own side effects, so you can use malathion. Actually, this drugs which I've kept on my slide is recommended by the National Vector Control Program government, because malathion is a very good alternative to your DDT. Then you also have Fenthion, which is the latest multi-potent anti-larvicidal insecticide. Fenthion. You have Pyrithium. Then you also can use this Gambusia fish, which is kills the larvae or anti-larvicidal. You can just put them in your ponds, lakes, and all. Then commercially, if you're talking about the things in the market, you have lot of what do you call good nights. I think it's our life started with those sprays, the what do you call the rings where we used to matchstick, and you have the coils. Then you had this what do you call good nights, all outs, jet, whatever it is. Then came down. Then you have these creams like Odomus and all that you apply. But at the end of the session, I think carry message would be, yeah, it's all good, but they have their own side effects. A lot of people are allergic to it. People, this it has its own side toxic effects, inhalation of those sprays and stuff like that. And but last but not the least, even WHO books, if you just take out your community medicine books and all, nothing like the nets that should be used. Mosquito net is the only best mechanical barrier that can prevent you from having a mosquito bite. Very conservative, very economically friendly. You don't have all the side effects with those nets and all. So always when you're going for hiking, camping in your domestic areas, or like outings, you can use mosquito nets as the best preventive measure to prevent bite of any vectors which you talked upon. So having said that, I think uh, this would be the last slide. Thank you for your patient hearing. I would ready to take up your questions if anyone has. I leave it to the organizers.
Thank you very much, Dr. Sab. Dr. Khaleel, there was a very informative webinar, I would say, and you covered the subject at hand was extremely vast, and 45, 50 minutes is really not enough time to cover a subject so vast and still delve into a lot of detail. Now, given that the subject was about vector-borne infections, uh, and we were looking at it from the Indian perspective, right? You talked a little bit about government policies with respect to initiatives, respect to controlling vector-borne disease in India, and you talked about why things are a little different India versus internationally. But I'd like to know your opinion on how does our situation with vector-borne disease incidence compare with other similar countries in the tropics? I'm not comparing with the Germany or North America. If we compare it with something like, in the same latitude that we have in terms of Burma, in terms of the Southeast Asia, where also things like dengue are quite prevalent, right? So how do you compare Indian scenario with that?
Yeah, India is still a developing country. Unfortunately, it's not in that cream of developed country. But as you can see, our map in the global area, we have still low socioeconomic when you're talking about the status of the income and the ratio when you talk about the population, the density, and family members in those areas. There are a lot of still, I think 60 to 70% people still in the rural area, the tribal areas and all. So there are about 40, 50 that in the urban area, but even urban area is not spared because now what we have to look out is the sanitation, the disposable of things, the looking at the environment. So hence looking at this setup and the literacy and the attitude behavior of the people, I think still we have, it's a wake up call. Definitely the incidence and prevalence is depending upon the seasonal variations and all, it is there. When you're comparing to the Western outfit and all, and again, the vaccines and all, the availability and all, people, the awareness and sensitization is much less. It's
For
not being
COVID,
percolated to the areas where it has to go. I mean, the common man has the message has to go to the common man to how to know. I mean, he has to get aware and sensitized about these measures. So how to keep his and be literate and educated and usage of the vaccines prevent over there. So definitely prevalence incidence is there. It's been rising, and government is trying its hard to bring under control. Still, we have deaths with dengue. Still, the outreach management has not been covered efficiently. I think I can say that.
I was recently in Karnataka, and Dr. Khalil, I was doing a little study in the field of scrub typhus. What came across to me was that scrub typhus, it's a deadly disease, yes, but most medical practitioners prefer to just you know do a wheels Felix test, give around a doxycycline, and let things work out. Well, we all know wheel Felix is a very non-specific test, and doxy is a solution, but not, it's a very broad spectrum treatment. It's not a specific treatment for specifically for scrub typhus. So, and these are all respected medical practitioners who say there is no scrub typhus. I explained to them that given the changing climatic conditions, uh, the the area that could be covered by any of these vectors today, whether it's a mosquito, whether it's a tick or a mite, has increased. Seasonality has also decreased, right? What do you think, in your opinion, whether a company or the government we can do to increase the awareness of these particular diseases? Because what India 10 years ago and India today are two different animals altogether.
Yeah, we actually our setup is like we do a lot of research, but I don't know how much authentic research are there, how many publications. We do a lot of publications. You just browse through, and there are so many publications on scrub typhus or so many things, and everybody does left and right, hook and corner. But there are some central institute. I don't say that government has failed in getting some data from central institutes like that. And definitely, I totally agree with you that it's no more seasonal. Actually, it has crossed borders because of global warming, deforestation, or whatever. We don't expect like this is a season where you have peak and something like that. Now these days it's like everything can anything can happen. So yeah, I mean we have to be prepared. Actually, we have to be prepared. And as I told, I mean the One Health concept which Dr. Narendra Modi sir, I mean the Prime Minister and government of Ministry of Health and Family Welfare has brought about is just a wake up call that it's not one man's job, it's not one industry or area, it is a multidisciplinary prong. And everybody has to come forward and share the experiences and give the inputs so that it could be a result oriented outcome. I have a good experience that I have been traveling with another very important scholar in Tamil Nadu, where he was just looking at the time and date, one of the in the lift actually. So I said, "What?" So I thought he was talking about some exams coming in. All no, he said we have to start gearing up because now dengue is going to come up. So 3 months before only, like he's preparing his like research tools and techniques, what pattern it could be. So that's
Well,
your
to be very honest with you, that I don't know if you're familiar with it. If you search on Google, there is a Google trend available, and they have data which is very conclusive. And trust me, it works because Google has mastered not just AI, but they have mastered the concept of search. So they're actually able to show with a lot of clarity the extent that dengue has happened, and for example, dengue or typhoid, for example, right? So Google is doing a very good job. They're able to highlight areas. It's just that nobody uses the data, right? It's just that nobody uses the data. So I agree with your scholar colleague when he said, yes, the dengue is due to come in anytime soon. It probably meant he was looking at a peak rather than the regular incidence, because dengue today is prevalent in some form or the other 24/7 throughout the year. I mean, I'm based in New Delhi. It's cold here, and we still have a few dengue cases. So, I believe that sometimes there's a lot of cover up. In fact, especially with dengue, they don't want, nobody wants the incidence of vector borne.
data.
uh, I had a quick question. There are 4 plus the new serotype, 5 serotypes of dengue. Is there a particular way we can differentiate between the 5?
Yeah, definitely. We have to go for, I mean, National Institute of Virology is a center where you can send anyway all these viruses which I'm talking about. Like you have Japanese B, dengue, and yeah, you can do next genome sequencing when you are very specific about exactly which serotype it is.
Okay, because because the treatment for each would be a little different, right? I mean,
Yes.
and unfortunately, in the real world, we are not able to do that. It's just pronounced as you're dengue positive, and go home and get some rest and drink some papaya juice. That's not the ideal medical approach to treatment of a disease. Also, I feel that there is a certain ignorance we have towards vaccines, right? There is a mental, maybe a barrier that we have towards vaccines. COVID was a unique case because even though a large section of the cross section of the Indian population did get vaccinated, a large cross section also did not get vaccinated. Do you think they're going forward in the long term, with new variants coming out for the COVID, less harmful variants, I would say, but we're facing a disparity in, illnesses because of vaccination and non-vaccination between people?
Yeah, definitely. I think this is not the right time and to comment on this because there's still a lot of research going on. Still, everybody is a question mark. Like, I mean, there's a lot of queries and controversies things over here. I mean, every day, as you can see, I mean, it's already 3 4 days that you have a person saying that nothing to worry, it's not that infectious. Transmissibility is fast, but it's not fatal. And somebody says again, I mean, it's like Jane one. See, this series has come COVID, and but preferably, I mean, end of the day, everybody has to maintain the social distance and neatness, cleanliness has to be there. So, again, you have another school of thought. People who have been vaccinated, they have a lot of cerebral vascular disease coming up, and deaths like 40 to 50, which we have been seeing post COVID actually. Even
Right.
I've just talked to a few of the cardiologists when I've gone for inspection in and around Hyderabad and Secunderabad. So they were saying it could be one of the reason. I mean, post COVID or vaccine could be responsible. So, and vaccine coming in a year, 2 years is, I mean, normally it takes a decade for any vaccines to be trialed and come out for FDA approval and all. What has happened and all. It's a very subject of discussion to be talk
That's an
about.
open, there are a lot of conspiracy theories around that, right? Not the forum, I guess, for that discussion,
Yeah,
but
definitely.
you're right. There are a lot of questions out there. And do we have any indigenous? Zika is another variant that's come out with, again, a mosquito vector-borne disease, right? Do we have any diagnostic options for Zika? Should it be PCR? What would you recommend?
Yeah, PCR would be the tool because we don't have rapid test for Zika. PCR would be because it's unusual and it's a biological weapon, I mean, bioterrorism weapon, and mostly again through chimpanzees. Again, here the vector is Aedes aegypti, most common in Zaire, the Caro, the African this thing, but it comes to India through a South country, I mean, South Indian country, and it's just transmit. Not that prevalent, but it's very fatal. And PCR would be the diagnostic of choice.
What do you see as the future of PCR, Dr. Khaleel? Because PCR is a very interesting technology. It's very effective and used correctly, right? But because of the pandemic, there was a high prevalence of PCR machines, and now things are moving back, towards using rapid ELISAs and chemiluminescence, for example.
Yeah, PCR would be actually, yeah, we have conventional PCR, we have a lot of PCR modifications of that, but I think coming years, as you said, what is the role of PCR? Yeah, you have a lot of modifications done. I mean, now you have something like Maltidorf, where you have the sample in, you have in 2 minutes, you have the result. You have biofair. So a lot of automation, lot of artificial intelligence is being pumped in, and the equipments and for accurate diagnosis with good specificity and sensitivity. I mean, waiting for PCR where you load the sample till the end of the day, I think those days would be also gone. I mean, now you have results in 90 minutes, 50 minutes, 20 minutes. Turnaround time has decreased. I mean, so much advancement technology has been done, robotics, and you have as I said, you have an instrument called Maltidorf, where you just have the sample and you get the result in 2 minutes. You have biofire, you have so many instruments. I mean, it's something like immunogrammatic test that's been happening. So that's the level of PCR where it has been based on that, it has come out with. So that's good news for us.
Right. Thank you so much, Dr. Saab. Very nice meeting with you and a very informative session that you have provided for today. We look forward to further such sessions with you on subjects of mutual interest, right? And I'm sure that as the year goes by, we will get such more occasions. We look forward to your presence with us, Dr. Khaleel.
Thank
Thank you
you.
very much. And thank you, ladies and gentlemen, for joining us today. We look forward to our next webinar in the month of January. Wish you all a very Merry Christmas and a very Happy New Year ahead. Thank you all. Have a good day.
Thank you, sir.